Hello and welcome to MK's medical review series. My name is Dr. Mosesjrk. We shall look at the last and indeed final lecture on the electrocardiography series. These are a series of videos that have been running that get you from being confused about the ECG to actually becoming an expert. And by this time, you should have actually been well versed with the ECG and the common pathologies that you need to look out for on the ECG to be very confident to walk on the wards, to be confident to see patients, and to actually be confident to make a diagnosis as a training as well as a health practitioner. In this review lecture video, I shall give you the important reminders that we have covered over the past week concerning the ECG. Remember that what are we looking for on the ECG? We're pretty much looking at the rhythm. We'll look at the P waves. Are the P waves peaked, indicating right atrial hypertrophy? Are they notched or broad, indicating a left atrial hypertrophy? We'll look at the cardiac axis. We'll look at the QRS complex. We ask ourselves, is it wide? If it's wide, then there's usually a ventricular origin or there's a bundle branch block. We look at the height of the QRS complex. If it's tall, that's usually going to be indicative of if you get this tall R waves in the lead V1, that's indicative of right ventricular hypertrophy. If you get this tall R waves in lead V6, that is usually indicative of left ventricular hypertrophy. We look at the transition point. Normally, it should be between lead V3 and V4, where the R and the S waves are equal. Then usually a clockwise rotation is going to be indicating chronic lung disease. We look for any Q waves that are present on the ECG that are pathological, which may indicate that there is actually an infarction in the interior aspect of the heart, depending on where the lead that has shown this Q wave is. Then you look at the ST segment. So usually there is raised ST segment in an acute myocardial infarction and in pericarditis, and it's depressed in ischemia as well as in digoxin. But remember, in ischemia is a horizontal depression, with digoxin is a sloping depression or a reverse tick. Then you look at the T waves. Are they peaked in hyperkalemia? Are they flat or prolonged in hypokalemia? Are they inverted in certain situations, such as in some leads, they are normally inverted, like for example in lead AVR. They're inverted in ischemia, they're inverted in infarction, they're inverted in left and right ventricular hypertrophy, they're inverted in pulmonary embolism, they're inverted in bundle branch block. Do you have any U waves that are present? This can be normal if the heart rate is slow enough or in patients with hypokalemia. So remember that the normal ECG has normal limits. Remember that the limits of the PR interval are 200 milliseconds or 5 small squares. The limits of the QRS complex is 120 milliseconds or 3 small squares. And the limit of the QT interval is 400 milliseconds or 2 large squares. Then the rhythm could you could have a sinus arrhythmia, you could have a supraventricular extrasystole, which are usually normal because you get these ectopic beats. Then the cardiac axis, normal axis of the cardiac axis, the QRS should be predominantly upwards in lead 1, 2, 3, and it's also still normal if the QRS complexes in lead 3 are facing downwards. So pretty much compare lead 1 as well as lead AVF and lead 2. Then in right axis deviation, the QRS complex is predominantly negative in lead 1, it's positive in lead 2, lead 3, and lead AVF. Then in left axis deviation, the QRS complex is predominantly negative in lead 2 and lead 3. And so you also look at lead AVF. Remember, right reaches, left leaves, and all good thumbs up. So everything is pointing upwards. So take note that there are some minor degrees of right and left axis deviation which happen within normal range. Then when it comes to the QRS complex, you may get these small Q waves which are normal in leads 1, lead AVL, lead V6. These are pretty much septal Q waves. You may get an RSR prime pattern in lead V1. This is normal if the duration is less than 120, but it may indicate partial right bundle branch block. If the R wave is smaller than the S wave in lead V1, The R wave is also going to be in lead V6. Is usually less than 25 millimeters. If it's greater than this, it may indicate that there's some ventricular pathology. If the R wave in lead V6 plus the R wave in, or plus the S wave in lead V1, these should be less than 35 millimeters. If they're greater than this, then this indicates that there is a left ventricular hypertrophy. Then of course the ST segment should be at the isoelectric line. Remember that the T wave may be inverted normally in lead 3, lead AVR, lead V1, and in black individuals in lead V2 and V3. There are some conduction abnormalities that we looked at. The first degree block, where there is one P wave for each QRS complex. The only thing that changes is a PR interval that is greater than 5 small squares. Then we also looked at second degree heart block, where there is a type 1, which is known as Wenck-Back phenomenon, where there's a progressively increase in the PR interval until you do not conduct the beat, where you lose a QRS complex. Then you have a Morbitz type 2, where there is occasional, there's some beats that are not conducted. You may also sometimes get a 2-to-1 block or a 3-to-1 block, where you get 2 P waves and 1 QRS complex, or 3 P waves and 1 QRS complex. You may sometimes get a complete heart block, where there's actually no relationship between the P waves and the QRS complex. You usually get a wide QRS complex because the impulse is being transmitted abnormally in the ventricles or to the ventricles. Usually the QRS complex rate is less than 50, and sometimes you may get a narrow QRS complex, but the rate will be 50 to 60. You may also get a right bundle branch block. Usually the QRS complex is broad, greater than 120 milliseconds. You may get an RSR prime wave, so it looks like an M pattern in right bundle branch block. So usually there's a dominant R prime wave in V1, and there's an inverted T wave that you see in lead V1, sometimes in V2 and V6. You may get a deep and wide S wave that you see in lead V6. That's indicative of right bundle branch block. Then in left bundle branch block, you get a QRS complex duration that is greater than 120 as well. You get an M pattern in lead V6, and sometimes in lead V4 and V5. There are no septal Q waves that you can see, and of course an inverted T wave in lead V1, lead 1 and lead AVL, lead V5, V6, and sometimes even V4. You may sometimes get a bifascicular block. Remember that the left bundle branch is divided into an anterior as well as a posterior bundle branch. So if you have a left anterior hemifascicular block, this is marked by left axis with deep S waves in lead 2 as well as lead 3. You may also get right bundle branch blocks, so you get these features over here. Then we looked at some rhythms. We may have a supraventricular rhythm. So in general, these have a narrow QRS complex, which is less than 120. They have the same QRS complex as in sinus rhythm because the impulse is being conducted normally in the ventricle, and therefore they'll also have a normal T wave. The only exception is a supraventricular rhythm that has a very wide QRS complex, like for example in a bundle branch block or Wolff-Parkinson-White syndrome. You may sometimes get ventricular rhythms, and in general, these are going to be having a wide QRS complex that is greater than 120. They'll have different QRS complexes from those that we see in the sinus rhythm, and of course abnormal T waves because the impulse is being carried abnormally in the ventricles. The rhythm, some rhythm abnormalities include extrasystole, where there's a single early beat that usually suppresses the next sinus beat. You may sometimes get an escape beat, where there's an absence of a sinus beat that's followed by a later single beat. So it's like the other tissues escape. You may sometimes get tachycardias or bradycardias. So some common supraventricular rhythms include sinus rhythms, atriosystoles, junctional extrasystoles, atrial tachycardia, atrial flutter, atrial fibrillation, junctional tachycardia, and junctional escape. Then some common ventricular rhythms include ventricular extrasystoles, ventricular tachycardias, ventricular escape, ventricular fibrillations. All these are topics on their own. Then some supraventricular rhythms could, with the sinus rhythm, you get 1 P wave per QRS complex. The PP interval varies with respiration, so that's a sinus arrhythmia. Then with a supraventricular extrasystole, you get an early QRS complex. There's usually no P wave because the sinus isn't, or the ectopic beat may not necessarily come from the SA node, and usually there's an abnormally shaped P wave if it's present, and there's a normal and narrow QRS complex because the impulse is being carried normally in the ventricle, so it means there will also be a normal T wave, and usually the P wave is like the reset. Then you may have an atrial tachycardia where the QRS rate is greater than 150. You get these abnormal P waves, and usually there's a short PR interval, usually 1 P wave per QRS complex, but sometimes the P wave rate could be about 200 to 240, and you may get a 2-to-1 block. Then in atrial flutter, the P wave rate is about 300 beats per minute. You get a sawtooth appearance. You may get an atrial flutter with a 2-to-1 block, sometimes a 3-to-1 block, sometimes even a 4-to-1 block. Usually if you apply a carotid sinus pressure, you may increase the delay of the AV node and worsen this block. So you may start off with a 2-to-1 block, then eventually get a 3-to-1 block. With atrial fibrillation, this is the most irregular rhythm of all. So remember that the muscles of the atrium are contracting individually. The QRS complex rate is usually over 160 beats per minute without treatment, but it can be slower. There are no P waves that you can identify, but usually there's a varying and completely irregular baseline. Then with junctional tachycardias, usually these are commonly but inappropriately called supraventricular tachycardias. Usually there are no P waves. The rate is usually 150 to about 180 beats per minute, and carotid sinus pressure may actually reverse this to sinus rhythm sometimes, and sometimes it doesn't. Then you may get escape rhythms. So these are usually bradycardias, otherwise they are just like we have characterized above, and except in atrial fibrillation, so you do not have an escape rhythm in atrial fibrillation. Then of course with ventricular rhythm, you may get ventricular extrasystoles where you get an early QRS complex. There is no P wave, usually because the problem is in the ventricles. There will be a wide QRS complex and an abnormally shaped QRS complex, as well as an abnormally shaped T wave. The next P wave is on time. Remember here it's much more delayed in the atrial rhythms. And then with ventricular tachycardia, there are no P waves, and the QRS complex is also broad, so greater than 160. The rate is greater than 160 beats per minute, and you could also have accelerated idioventricular rhythms. So as for ventricular tachycardia, but the QRS complex is less than 120 beats per minute. Then you may sometimes have ventricular fibrillation, so please look at the patient, not the ECG. This is very easy to diagnose. Sometimes you may get myocardial infarction. So remember the normal sequence of the changes. You may sometimes start off with a normal ECG, then you have raised ST segment elevation, then you may have appearance of the Q wave, then the ST segment may come back to the baseline, then you may get T wave inversion, which usually is permanent. And usually the leads where this happens, that's where you get the site of the infarction. So if it's an anterior infarction, you get these changes in lead V3 and V4, but often also in lead V2 to V5. If it's an inferior infarction, you get changes in lead 3 and lead AVF. If it is a lateral infarct, you get changes in lead 1, lead VL, lead V5 and V6. If it's a true posterior infarction, you get a dominant R wave in lead V1. Then possible ECG patterns include a normal ECG with sinus tachycardia. You may get peaked waves, you may get a right axis deviation, you may get right bundle branch block, you may get a dominant R wave in lead V1. Remember that the R wave is bigger than the S wave in lead V1. Then you may get inverted T waves in lead V1 and V3. You may get deep S waves in lead V6. You may get right axis deviation. So you may get S waves in lead 1. You may get Q waves as well as inverted T waves in lead 3. Then you may also get hypertrophy of the heart on the ECG. So with right ventricular hypertrophy, you get these tau R waves in lead V1. You get tau or T wave inversion in lead V1 and V2, sometimes in V3, and in some cases in V4. You get these deep S waves in lead V6. You may get right axis deviation also in right ventricular hypertrophy, and sometimes right bundle branch block. Then in left ventricular hypertrophy, you get these R waves in lead V5 and V6 that are greater than 25 centimeters. And then the R waves in lead V6 plus the S waves in lead V1 and V2, if they are greater than 35, then you make a diagnosis of left ventricular hypertrophy. You may get sometimes T wave inversion in lead 1, lead AVL, lead V5, V6, and sometimes lead V4. In left atrial hypertrophy, you get a bifid P wave, which are known as a P mitrale. In right atrial hypertrophy, you get this peaked P wave, which are known as P pulmonale. Now, the differential diagnosis of ECG, we can rearrange some of these lists to remind you of possible implications of ECG patterns. So a P wave to QRS complex, apparently not one-to-one. So if you cannot see one P wave per QRS complex, consider the following things. So if the P waves are present but not easily visible, look at lead 2 as well as lead V1. So if the QRS complexes are irregular, then the rhythm is probably atrial fibrillation, and what's seen to be P waves may actually not be P waves, so they may be F waves. So if the QRS complex rate is rapid and there are no P waves and there's a wide QRS complex, this means that the problem is from the ventricle. So you could have a ventricular tachycardia, or you could have a narrow complex QRS or you could have a narrow QRS complex, which is going to be indicating junctional tachycardia. And then if the QRS rate is slow, then it is probably an escape rhythm. So with a P wave to QRS complex that is greater than 1-to-1, so here you have more P waves than the QRS complex, you consider the following things. So if the P wave rate is greater than 300 beats per minute, then the rhythm is probably atrial flutter. If the P wave is 150 to 200 and there are 2 Q waves per QRS complex, then the rhythm is most likely atrial tachycardia with block. Then if the P wave rate is normal, like for example 60 to 100, then and there is a 2-to-1 conduction, the rhythm is sinus, and usually there is a second degree heart block. Then if the PR interval appears to be different with each beat, then consider that to be complete or third degree heart block. Sometimes you may get a wide QRS complex. So if there's a wide QRS complex, this usually indicates a sinus rhythm with bundle branch block. It could indicate a sinus rhythm with a Wolff-Parkinson-White syndrome. It could indicate ventricular extrasystoles. It could indicate ventricular tachycardia. It could indicate complete heart block. If you get Q waves, these are usually normal in leads 1, AVL, and V6. The Q waves in lead 3 can be there, but not AVF. So you do not have them in AVF. And if the Q waves are there, it probably indicates that there's infarction if it's present in more than one lead. And if it's longer than 40 milliseconds in duration and deeper than 2 millimeters, so deeper than 2 small boxes. Then with the Q waves in lead 3, but not in lead AVF with right axis, may indicate pulmonary embolus. Then leads showing Q waves indicate usually the site of the infarction. And remember, these Q waves are pretty much permanent. Then with ST segment depression, it could be with digoxin, so this is usually slanting, or it could be with ischemia. This is usually a flat ST segment depression. Then you may get some T wave inversion, which are normal in lead 3, lead AVR, lead V1, in lead V2 and V3 in black individuals. You may get T wave inversion in ventricular rhythms, in bundle branch block, in myocardial infarctions, in right or left ventricular hypertrophy, as well as Wolff-Parkinson-White syndrome. That is a summary of everything. If you haven't gone through the videos and you have watched this video straight, I'm sure that felt overwhelming, because even after you've gone through the videos, it may be overwhelming to some extent. So sit down and actually watch through each and every individual, and make sure you and make sure you understand each video before moving on to the next, because the principles of the previous video build on the next video. And that is everything that I've had for you on the ECG week. I hope you have really enjoyed. Please share this playlist, subscribe to the channel, hit the bell notification or the bell icon to be getting notifications every time I post a video. Thank you for spending your time in ECG week. Until next time, my name is Dr. Moses Kazevu. Bye-bye.